Greetings. We're going to talk in this section about stress urinary incontinence. This is the most common form of true urinary incontinence in women. We'll start off with the vignette. A 54-year-old woman presents to the clinic complaining of intermittent urinary leakage over the past 9 months. She says that it primarily happens when coughing or laughing, and it is in small amounts. She requires the use of pads to keep from wetting her clothes, and this has become quite bothersome. She denies urinary urgency and says that she voids about 5 or 6 times per day. There is no incontinence at night. She denies any pain on urination or any blood in the urine. She is a G4P4, all uncomplicated spontaneous vaginal deliveries. Her last menses was 3 years ago. The vagina and bimanual exam are unremarkable. What is your next step at this point? That would be a common question on step 3, possibly step 2. So your next step is going to be a urinalysis. Why do you want to get a urinalysis? Because anytime you have a patient with urinary incontinence, it's very easy, very cheap to rule out a urinary tract infection. And urinary tract infection is a common cause of urinary incontinence. Now, that being said, urinary tract infections tend to cause increased urgency, and we don't see that in this patient. Urinary urgency would be defined as more than 8 times urinating per day or more than 2 times at night. This patient only urinates 5 or 6 times per day. She doesn't describe any problems at night. So this is likely not a urinary tract infection, but we want to check anyway. And indeed, the urinalysis comes back negative for a urinary tract infection. Typically in a urinary tract infection, we would see white blood cells, some red blood cells, probably nitrates as well. Culture is pending. Okay, so probably not urinary incontinence, or probably not urinary tract infection. What else are we going to do as part of the physical examination? Because this is so suspicious for stress urinary incontinence based on the history and based on this woman's age, we're going to do what's known as the Q-tip test. We'll talk about this in a little bit greater detail later on in this lecture. Q-tip test, what it essentially is doing is it is measuring the amount of hypermobility, if there is any, but measuring the amount of mobility of the urethra, and that is associated with stress urinary incontinence. And a normal urethral mobility would be 30 degrees from the horizontal plane, and anything greater than that would indicate urethral hypermobility, which is associated with stress urinary incontinence. So what do we have here? This is a presumptive diagnosis of stress urinary incontinence. The only way to make a formal diagnosis would be through urometrics, but that's generally not needed unless the patient is going to be requiring surgery. So how do we know this is stress urinary incontinence? First of all, stress urinary incontinence is the only urinary incontinence out of the 4 major types that we're going to talk about that does not give you symptoms at night. Stress urinary incontinence is the urinary incontinence that you get when you sneeze or you cough or you laugh and a little bit of urine comes out. But it is not going to cause that feeling that you need to go at random times frequently throughout the day. All it is you cough or you sneeze and a little bit of urine comes out. Now that being said, it's not trivial. Okay, so these women, it can be just small increases in their intra-abdominal pressure, just small Valsalva issues where it leads to a loss of urine. And all it takes is a little bit of loss of urine and you get wetting of your clothes. And that's a problem because you lose urine and that urine starts to smell and then the woman smells and it's not fun. And they get wet with time and they require use of pads, and this really begins to affect their quality of life. So it's not trivial by any means. However, these women are not the ones that are going to need to be running off to the bathroom. They're not going to be urinating 10, 15 times a day. Essentially what their incontinence is it's a loss of urine when they're coughing or sneezing. They do not have symptoms at night. That's important to remember as well. Typically, these patients will be postmenopausal. The reason is because as estrogen levels drop, the support structure of the pelvic floor begins to wane a little bit, and that is ultimately what also is going to give rise to that hypermobility of the urethra. It also is going to make it more difficult to transmit higher intra-abdominal pressure to the urethra, and so you just get increased pressure in the bladder, not increased pressure in the urethra. And remember back to sort of your urodynamics, if you have high pressure in the bladder, but you don't have a concurrent increase in pressure in the urethra, then you've got a gradient, and urine is going to move out of the bladder into the urethra, and that's going to cause incontinence. All right, so let's talk about this in a little bit greater detail. So this is sort of a list of the 4 different major types of urinary incontinence. You can see that with stress incontinence, the major feature here is that you have no nocturnal symptoms, and that the Q-tip test is going to be positive, indicating urethral hypermobility. So here's our bladder here. So you have the detrusor muscle. They spelt it wrong here, but the detrusor muscle is what's going to contract, allow you to urinate. The ureters are coming in here. What's known as the trigony of the bladder, or trigony, potato, depends on how you want to pronounce it. This is just a triangle between the 2 ureteral orifices and the outlet of the bladder. You have the sphincter here. You have an internal and external urethral sphincter. The pelvic floor here, which is made up of various structures, levator ani, these perineal muscles, and then pubourethral ligaments. Okay, so these make up sort of the floor of the pelvis. All right, so what you have with stress urinary incontinence is you have the urethra, which is no longer well supported by the pelvic floor, and so because of that, it's more difficult to transmit abdominal pressure to the urethra. You can transmit abdominal pressure to the bladder, but you can't transmit it to the urethra as you should. And so what's going to happen is you get an increase in pressure in the bladder, increased intravesicular pressure, but the pressure in the urethra is remaining the same. And so the pressure gradient is going to favor urine moving out of the bladder. On the other hand, normally, if you were to have normal support of the pelvic floor, that intra-abdominal pressure would be transmitted to the urethra. So you would have increase in intravesicular pressure, but a concurrent increase in the intraurethral pressure, and so the gradient would not change and you would not lose urine. So this is generally due to a loss of support of the pelvic floor and hypermobility of the urethra, and that is going to be how we wind up treating this, as we're going to see. So the history of patients with stress urinary incontinence, typically they're postmenopausal. They don't have to be, but that tends to be the case because hypoestrogenism, or a decrease in estrogen, is going to predispose the patient to a weaker pelvic floor. They tend to be multiparous. That itself has a tendency, just childbirth in general, has a tendency to weaken the pelvic floor a little bit. And then gynecologic surgeries for the same reason. What are some risk factors? Age is a big risk factor. So the older the woman is, the less estrogen she's probably going to have, the weaker the pelvic floor is going to be, etc. Another thing that can be a risk factor is race. White women are more likely to have stress urinary incontinence, whereas black women are relatively more likely to have urge urinary incontinence. This is a general rule of thumb. Obesity. Why obesity? Because women who are obese, anybody who's obese, has a higher intra-abdominal pressure, and that's going to put pressure on the bladder. Although typically that pressure is transmitted to the urethra, if you just have a higher intra-abdominal pressure in general, that's going to make your stress urinary incontinence, when it comes on, it's going to make it worse. Smoking. Why smoking? Smoking decreases your estrogen, plain and simple. So there is a causal link between smoking and stress urinary incontinence. Another reason, probably a little less contributory, is that people who smoke are more likely to have COPD. People who have COPD are more likely to have a chronic cough. Coughing increases the intra-abdominal pressure and can exacerbate stress incontinence. We already talked about hypoestrogenism, and in family history, I believe if you have a primary relative with stress urinary incontinence, your relative risk is about 1.3 or 1.4. What are the symptoms? These women are incontinent of urine during Valsalva. So that can be a lot of different things. Coughing, sneezing, lapping, lifting, orgasms, intercourse, standing up from sitting down. So you can see that it's not just little things that, or it's not just big things that cause this. It can be a lot of different things that happen in the course of your day. And so losing urine that frequently can be really problematic because these women have to have pads in, those pads get wet, they have to change the pads. It can just become really problematic. Now, this is technically intermittent urinary loss because it only happens when the intra-abdominal pressure goes up. If they're sleeping, if they're laying down, not doing anything, they're not going to be incontinent of urine. That stands in contrast to urge urinary incontinence, where the woman could be laying down, watching TV, totally relaxed, all of a sudden, boom, she's got to go and urinate, otherwise she's going to become incontinent. That doesn't happen in stress urinary incontinence. It's only triggered by these stressors. However, it is persistent in as much as if you're walking about doing the activities of daily life, it's going to happen frequently because you sit down and stand up frequently. You lift things frequently. You can cough several times throughout the day. You can sneeze several times throughout the day. So it's persistent. And it can be so persistent that it can be described as continuous, even though technically it is intermittent, not continuous. Okay, so hopefully you get the kind of the difference there. It's not continuous like urge urinary incontinence where you really can't control it at all. Technically it is controllable in as much as if these women were to just lay flat, not do anything, they're not going to be incontinent. But by doing the activities of daily life, it will be continuous because all it takes is little things to increase that intra-abdominal pressure. And there's various severities of the stress urinary incontinence. So with some women it takes a lot more. Some women it just is little things and they can become incontinent. Now the amount lost with each episode is small, 10, 20, 30, 50 mils. But it adds up throughout the day if they're having several episodes, and that can necessitate frequent changing of pads. They do not have symptoms at night. This is the only one where they don't have symptoms at night. With urge urinary incontinence, they're going to be waking up in the middle of the night to go to the bathroom. With overflow urinary incontinence, they're going to be dribbling out urine all the time, even at night. With bypass urinary incontinence, same story. Okay, so this is the only one where there's no symptoms at night. Think about it. You're laying down. You're not going to be having that increase in intra-abdominal pressure, provided you're not waking up in the middle of the night coughing or something like that, but they're not going to have symptoms at night, provided they're sleeping soundly. And there's also no urgency or increase in frequency. All this has to do with is you have an increase in intra-abdominal pressure, it doesn't transmit to the urethra, they lose urine. Okay, that's the cause here. There's no problems, generally no problems with the nervous system, there's no problem with the detrusor muscle. It's just an anatomic problem. Now, that being said, you can have a stress urinary incontinence issue if there's problems with the sphincter, but that's not as common. The physical exam is generally unremarkable. So you can note some signs of atrophy in the external genitalia. That would be atrophic vaginitis. And the reason is because stress urinary incontinence is associated with hypoestrogenism. Atrophic vaginitis is associated with hypoestrogenism. And so you can see the two of them concurrently. You should not note any vaginal diverticula. That would be consistent with bypass urinary incontinence. The bulbal cavernosus and anocutaneous reflexes should be normal, and that indicates an intact S2-S4 pudendal circuit. So all this is a reflex. Bulbal cavernosus reflex is pretty easy to elicit. All you do is when you're doing your vaginal exam is lightly brush the external part of the genitalia, labia majora, and you should see a contraction of the anus. And this is a reflex, the bulbal cavernosus reflex. Now, when you're doing your vaginal exam, it can be useful to ask the woman to strain. because if you note a loss of urine while she's straining, so just have her cough or bear down, if there's a loss of urine, that's going to be very consistent with stress urinary incontinence. Okay, what is this Q-tip test we've been talking about? Okay, we'll talk about that in a little bit. Okay, so the Q-tip test, what you do, generally it helps to take this little Q-tip and put it in some topical anesthetic gel. But what you're going to do is you're going to insert this cotton tip applicator into the urethra all the way up to the junction between the bladder and the urethra. You got to make sure that you get it all the way in. Then you will you'll have this on a horizontal plane. So where it is at resting is going to define your horizontal plane. What you then have the woman do is bear down, and that is going to raise the cotton tip applicator. It should not raise any more than 30 degrees. If it does raise more than 30 degrees on Valsalva, then what you have, if it's more than 30 degrees, is urethral hypermobility. And what that means is that there is probably some anatomic weakening of the pelvic floor. And that is consistent with stress urinary incontinence, because if you have a weakening of the pelvic floor, then it's going to be much more difficult to transmit that intra-abdominal pressure to the urethra, and that means that you're going to have higher pressure in the bladder than in the urethra, and that is going to cause you to lose urine with Valsalva. Okay, so this is just a schematic of how this works. So normally when you have increased intra-abdominal pressure, it transmits both to the bladder and to the urethra, which means you're going to have a concurrent raise in pressure, and so you will not have a pressure gradient. On the other hand, if the urethra is, if the pelvic floor is weakened, the urethra is hypermobile, you'll have an increase in bladder pressure, but no concurrent increase in urethral pressure, and that's going to favor the movement of bladder out on Valsalva. So for diagnosis, as mentioned, all patients should get a urinalysis with culture, regardless of the suspected diagnosis, just because it's so cheap to get, and a urinary tract infection, if it is there, you can treat that. All right, so get a urinalysis. That should be normal in just regular old stress urinary incontinence. The initial diagnosis of stress urinary incontinence can be made clinically. However, if you wind up deciding that you want to go forth with surgery, and that's certainly not the first line of therapy, but ultimately a lot of these women will go on to require surgery. If you do decide you need to go on to surgery, then you should get further workup. So you should get urodynamic studies to formalize the diagnosis. But that's not necessary to make your initial diagnosis and to start conservative management. So what are you going to be doing with urodynamic studies? Normally, during Valsalva, the intraurethral pressure and the abdominal pressure will increase together. In stress urinary incontinence, you will find the intraurethral pressure does not rise with the abdominal pressure, or at least rise to the same degree as the abdominal pressure. Your post-void residual, which is part of your urodynamic studies, that's going to be normal. There's no problem with getting urine out when the woman decides she wants to void. All right, and that is going to stand in contrast to overflow urinary incontinence, where you can get dribbling of the urine on Valsalva, but the problem there is that you have too much urine in the bladder, and that's going to cause your increase in intravesicular pressure. Okay, so what are the etiologies of stress urinary incontinence? As we talked about, the most common cause is weakening of the pelvic floor anatomy, commonly due to hypoestrogenism, and that would be something like menopause. You can also get stress urinary incontinence from direct injury to the pelvic floor. This is not terribly uncommon in postpartum women, although I would say probably the more common urinary incontinence is going to be an overflow urinary incontinence secondary to local anesthesia. I'm not exactly sure about the statistics there, but this is not an uncommon problem for postpartum women. So you get injury to the pelvic floor, particularly if it's a traumatic childbirth, and you can get some stress urinary incontinence there. This can happen during pregnancy just because it increases the intra-abdominal pressure, particularly against the bladder. So you have a baby's head pushing up against the bladder, and that can increase the intravesicular pressure enough to where you can get a stress urinary incontinence. That being said, in addition to pregnancy, masses in the pelvis can cause this too. Obesity, just because it increases the intra-abdominal pressure, smoking, and then certain medications. So alpha adrenergic antagonists, that's going to relax the urethra and decrease the intraurethral pressure. Some antipsychotics and antidepressants, they have alpha adrenergic antagonism as part of their properties. ACE inhibitors can do it because you can get that cough with ACE inhibitors, and that can typically that would worsen your stress urinary incontinence, but the fact is some women have such mild stress incontinence that it's subclinical, and so if something happens where they're getting significant cough, then they can start to manifest the symptoms of their otherwise silent or subclinical stress urinary incontinence. How do we manage this? So the first step is going to be conservative management. We don't want to do surgery on every single woman because it's expensive, and most women will respond to conservative management. So the first step is going to be behavioral modifications. And you can do these at the same time too, but behavioral modifications is probably the easiest. So scheduled bathroom visits. Why does this work? Well, some women only have symptoms of their stress urinary incontinence when their bladder fills to a certain volume. So some women, let's say 350 mils of volume in their bladder. Remember that as the bladder fills, the pressure goes up. So if they have less urine in their bladder, some women will not manifest symptoms until they get to a certain volume. So let's say 250 mils of urine. If they're below that, they don't have any symptoms. They can cough, they can sneeze, they don't lose urine. If they get above that, then they start to have symptoms. So working on that premise, if you tell a woman, schedule your bathroom visits, even if you don't feel like you have to urinate, go every 2 hours, or go every 3 hours, or hour and a half, or whatever. If they go frequently enough and they don't let their bladder fill to that threshold, then they're not going to have symptoms. So like it says here, many women only experience their symptoms when the bladder reaches a certain volume. So keep yourself below that. You can get rid of your symptoms, and all it takes is scheduled bathroom visits. In addition to this, you can strengthen the pelvic floor. This is called Kegel exercises. You can look up how to do this, how to counsel a patient how to do this. Essentially what they're doing is they're relaxing or contracting their pelvic floor muscles, and it's just like isotonic exercises that you do at the gym. So that's called Kegel exercises. It strengthens the pelvic floor, and that can help with transmitting that pressure to the urethra. Pessaries can be placed. There's specific special pessaries that can be used to help support the urethra. Those are placed into the vagina, and that can help as well. And pessaries are very useful if there is stress urinary incontinence in conjunction with some degree of pelvic organ prolapse. Surgical management, there's a lot of different ways you can approach this. So there's urethral bulking agents. These are injected to provide some support to the urethra. There's retropubic urethropexy. This is sort of an old-fashioned way, but there are a couple different ways that this can be done. There's one called the Birch procedure, another called the MMK. I can't remember the names behind that. It's Marshall Marchetti Krantz. But essentially what you're doing here is you are suspending the urethra up against the symphysis pubis. So this is a urethropexy. And then another, this is a little bit more common now, procedure that can be done, what's called a sling procedure. There are a couple different types. Pubovaginal sling procedure. Essentially what you're doing here is you're taking autologous fascia, usually from, I think they can take it from the tensor fascia lata in the leg. And what they do here is they attach this fascia to the anterior abdominal wall and then reinforce the bladder neck. And then there's another called the midurethral sling, and that they take synthetic, like a synthetic mesh or tape, And there's a couple ways they can go about doing this. There's 2 different approaches. I'll show you some pictures. Don't worry about knowing the details of these surgeries. Just know there's various ways these can be gone about. If you are an OBGYN resident or you're on an OBGYN rotation and you work with a urogynecologist, you will see these surgeries done and will probably make more sense. But I'm not going to go into it in great detail. What I want you to know is that surgery is a second line of management. We try to do these sort of more conservative managements, behavioral modifications, Kegel exercises, pessaries, before we go on to do surgeries. And remember, if you're going to do surgery, you need to do a more formal diagnosis, generally urodynamics, before you go about this, because you want to know, is this just stress urinary incontinence, or is there an urge component here too, where some pharmacologic management might be useful? This is the 2 urethropexies. So you can see what they're doing is they're suspending the urethra to various structures in the pelvis. Okay. This is one of the sling procedures. This is the pubovaginal sling procedure. In this case, you would take autologous fascia, generally from the tensor fascia lata in the leg, and they are just it's kind of working the same way, where they're taking the fascia and they are sort of reinforcing or suspending the urethra. And here they're suspending it against the anterior abdominal wall. Okay, so here's another approach that can be done. All right, so stress urinary incontinence, some of the things that make this stand out is that there are no nocturnal symptoms and that the Q-tip test will be positive. Some of the other incontinences, like urge urinary incontinence, that's going to be set apart by the frequency and urgency. They're going to be going more than 8 times a day. They're going to be going at night. If they do have incontinence, it's going to be a large amount. Their bladder is just going to lose all the urine it's got. It's going to be 200, 300, 400 mils of urine. A lot more than in stress urinary incontinence, where you're usually only losing 20, 30, 40 mils. Overflow urinary incontinence, what's going to set this apart is that they are not able to void voluntarily. So here, the problem is generally neuromuscular, although this can come from pharmacologic agents, from anesthetics. If there's a neurologic problem here, that S2, S4 reflex is going to be diminished or absent, whereas this will be normal in stress urinary incontinence. So stress urinary incontinence is not a neuromuscular problem. And in the bypass urinary incontinence, there's generally fistulas here, and so that will be noted, although note that bypass and overflow urinary incontinence look very similar, with the exception that bypass urinary incontinence, typically they can void voluntarily. Okay, so we'll talk about the rest of these in the other sections, but hopefully you get a good idea here what stress urinary incontinence is.